You're listening to the Smart Policy Podcast, a production of the University of Tennessee's Institute for Public Service. It is increasingly well understood that the criminal justice system is one of the most significant and valuable intervention points for getting people into recovery. When people are given access to the services they need to enter and maintain recovery, the success stories are common.
And so we need to make sure that the resources are available in our jails to provide treatment, to get people screened for substance use disorder, to get them started onto treatment, and then to give them a warm handoff into the community to make sure that that treatment continues.
But providing those resources in jails can be tough, especially in small rural counties. For one, there are a number of policies and laws that jails have to consider when seeking funding for resources.
And the moment you are arrested, so the moment that those handcuffs go on, then your health care is the responsibility of whoever is holding you. So if the county jail is holding you, your health care is their responsibility. Having the facilities carry the burden of paying for all of these inmates is really putting county budgets in particular in strain.
And worse, when addiction goes unaddressed, whether due to cost or lack of local services or other reasons, recidivism tends to be higher, which makes the problem even more expensive and even tougher for counties to solve.
What's really expensive here is not just healthcare, but it's the churn. It's the constant rearresting of people.
Our guest this month is Libby Jones of the Overdose Prevention Initiative. Her organization is currently working with the U.S. Congress on 3 bipartisan federal bills that seek to improve this situation: the Reentry Act, the Due Process Continuity of Care Act, and the Peer Support Act. In this conversation, we talk about what these bills seek to do and how they could potentially benefit county governments, the ongoing history of bipartisanship at the federal level when it comes to fighting the overdose crisis, how Tennessee legislators have been leaders in this fight, and finally, how the best policies tend to come from the local level.
Great policies need to bubble up to Washington instead of go push down from Washington.
As always, this episode is intended to be educational and is not to be taken as an endorsement or rejection of any legislation. Any opinions or views or specific language presented in this episode does not reflect the opinion of the University of Tennessee.
Thanks for having me. My name is Libby Jones. I'm the Associate Vice President of Overdose Prevention at the Global Health Advocacy Incubator. So we are a DC-based nonprofit. I live and work here in our nation's capital, and our team is devoted to finding federal policies that will help end the overdose crisis.
All right, so we are obviously mostly a state-focused show, but we do try to pull attention to federal policies that could really make a difference. Some of those recent ones, for example, that we've talked about, the MAT and MATE Acts, which removed the X waiver for prescribing buprenorphine. You actually recently mentioned Tennessee's connection in that. I wonder if you could, for the audience, give a brief recap of that.
Yeah, so, I personally had been working on the MAT Act since probably 2017, 2018. Just for folks who don't know what the MAT Act is, prior to the passage of this bill, there was something called the X waiver. So the X waiver for prescribing buprenorphine was, in addition to a prescriber having to be registered with the DEA, they had to go through extra training and extra registration and extra oversight from the DEA in order to prescribe buprenorphine to treat opioid use disorder. So we put ourselves in a scenario where we actually make it harder for physicians to prescribe treatment than it was for them to prescribe the medications which caused addiction in the first place, which was super counterintuitive. So as we were building this bipartisan base of support for the bill, just as when you're doing anything on Capitol Hill, we kind of hit a lull. We had a big movement forward, and then we started to see the momentum start to slow. And in the Senate, we were looking for Republican leaders to step up and co-sponsor this bill. For those who don't know, one common approach in the Senate is called the Noah's Ark approach to gaining co-sponsorship. So what you do is you find a Republican and a Democrat who will come onto the bill together and, who put their name on it on the same day so that it's bipartisan, it's split down the middle. And so we went to go see Tennessee Senator Marsha Blackburn, and we went to her staff and we talked about the importance of this bill. And not only did the senator agree to become a co-sponsor of this really important piece of legislation, I really give Senator Blackburn a lot of credit because her agreement to co-sponsorship then brought on Bernie Sanders, which they came on together.
Right, to talk about bipartisan.
I know, talk about bipartisanship, but they came on at the same day. And then we saw, it kind of opened the floodgates. And, Senator Blackburn was the senator who came on that then brought a number of Republican co-sponsors behind her who said, well, Senator Blackburn is on board. We can get on board too. And so I really, I think she deserves a lot of credit. And we're very thankful for that leadership. And then, we saw that bill pass with tremendous bipartisan support. We actually did an analysis at one point, and we found that in that Congress that ended in 2022, the MAT Act was the 31st most popular bill in terms of co-sponsorship. But 31 is actually probably fourth if you take out all of the renaming of post office bills and names going on stamps. So if you take those bills out, the MAT Act was definitely top 5 for that Congress. So
that's really, really, really crucial because that bill, for some broader context for folks, the extra training, the extra license that it took to prescribe buprenorphine, this led to, a lot of cash-only clinics. It led to further stigma about the whole switching one drug for another. So getting rid of all that allows primary care physicians, a whole lot of additional providers to provide medications for opioid use disorder.
Yeah. For all too long, for decades, there have been these federal regulations and state regulations that make it more difficult for people with a substance use disorder to get treatment than it is for them to access illicit drugs. And until we can get rid of that, we're not going to make tremendous progress. And the MAT Act was a great way of making it easier for people to get treatment.
Yeah, so thank you for that background because it's an interesting aspect. It was a major change in the law, and it was nice to see that Tennessee was part of that. That Tennessee leaders were in fact kind of driving the ship in a way.
Yeah. Senator Blackburn, I give her a lot of credit for that. So
yeah,
I don't even know if she knows that we give her a lot of credit for that.
Well, so what are some of the policy issues y'all are working on now? Because there's still a lot of work to be done. We're still seeing record overdoses, even though overdose fatalities are coming down across the country, and even more so than the national average here in Tennessee. We are still 4 times higher a rate of overdose deaths than when all of this started in the late 90s. So there's still plenty of work to be done. So what is it that you're working on these days?
Yeah, we are still really laser focused on access to medications for opioid use disorder. Medications for opioid use disorder, so methadone and buprenorphine, they are the gold standard for treatment across the globe. They are incredibly effective. We've got decades of evidence that proves that these medications work for folks. And so there's a number of policies that we're really focusing on. We really believe that we have to increase the locations where these medications are available. Increasing the number of medication units, for example, or mobile methadone treatment options. We need to make these medications as accessible as possible and remove those barriers that people are experiencing. We also need to expand Medicaid coverage. Medicaid is the number one payer of addiction services in this country. That holds true for TennCare. TennCare is the largest single payer of addiction services in the state of Tennessee. We need to address the issues around prior authorization. So we're working with Congress on addressing prior authorization requirements for these medications that make it more difficult for prescribers to prescribe these medications. We also need to make sure that these medications and treatment options are available in our carceral system. So we have a lot of very compelling data that shows that people who are incarcerated are a much higher risk than the general population of dying from an overdose. We know that someone being released from incarceration is 40 times more likely to die of an overdose 2 weeks after their release. Incarceration, I'm never going to say that incarceration is a substitution for treatment, right? Our jail system is not designed, nor should it be, a place where people go for treatment. However, we have to acknowledge that the majority of folks who are caught up in our legal system have a substance use disorder. And this is a critical point of intervention. And so we need to make sure that the resources are available in our jails to provide treatment, to get people screened for substance use disorder, to get them started onto treatment, and then to give them a warm handoff into the community to make sure that that treatment continues. It's only then that we're going to save lives from overdose, and we will reduce recidivism. This is one of those public health is public safety issues, and it's very clear. So we are working on 2 bills. One is the Reentry Act. This would allow folks who are current Medicaid beneficiaries to have their Medicaid benefits switched on 30 days prior to release, so that they can get connected with community providers. They can get started on medications. They can get started on treatment prior to release. Another part of that is the Due Process Continuity of Care Act. It's a mouthful, but what it does is it allows existing Medicaid beneficiaries to keep their Medicaid benefits up until they are convicted. This allows for folks who may be arrested who are already receiving treatment to stay on that treatment and not get disconnected from their treatment provider. But it also would allow folks to get screened when they are arrested. That screening process is covered under Medicaid. And so getting people screened and then connected to treatment during incarceration, they're going to have a much higher likelihood of not only surviving, but thriving once they get out of detention.
For my audience, I might want to open with the question, why is it not standard that people would be screened for addiction upon entering a carceral facility? For many people who don't understand how jails work, it seems like that would be, it should just kind of happen, right? But what barriers might exist for that?
Walk you back in time to 1965. So in 1965, the Social Security Act was created. And in that bill, which created Medicaid to begin with, there is what's called the MIEP, the Medicaid Inmate Exclusion Policy. So what that does is it says that Medicaid shall never be used to support medical treatment given during incarceration. It says basically anyone who is in custody, their health care is the responsibility of whoever is holding them in custody. So essentially, that has followed us now to 2025. And the moment you are arrested, so the moment that those handcuffs go on, then your health care is the responsibility of whoever is holding you. So if the county jail is holding you, your health care is their responsibility.
If I may quickly ask, is that somewhat similar to, say, like my health insurance is through my employer? Does that mean that the county jails have to purchase health insurance like an employer might for their incarcerated population?
From my understanding, different counties and different facilities have different models, but
Gotcha.
Basically the county government is responsible for paying those fees. So there are some who contract that out to, medical services, and some of these counties are, hiring their own medical staff to do it themselves. So what we've got is this huge patchwork of really thousands of different variations of this, right? But the fact is that, I don't have to tell you, county budgets are strapped. And healthcare is extremely expensive in these facilities.
Yeah.
And, having the facilities carry the burden of paying for all of these inmates is really putting county budgets in particular in strain. So some counties are doing this. Some counties are initiating people, screening and initiating people into treatment. They are using all kinds of creative funding to make that happen. They're using COSEP grants. Some states have these 1115 waivers, which allow them to access Medicaid services. But it's all, again, it's a very much a patchwork, and the folks who are doing it are having to do this in a very creative way because Medicaid is not available. They can't bill Medicaid for those services.
Right. Yeah, and we're also seeing opioid settlements being used across the country. It's not any one state that providing funding for treatment in jails is a very common expenditure with these funds. Yes. But I think the limitation of that also, there's only so much and for only so long, I think is part of the puzzle there. You mentioned several other grants. I was wondering if you could reflect on stability of funding real quick.
Oh, yeah, that's always the key, right? I mean, look at what's happening right now. Right now, we're in the 24th day of a government shutdown. Any type of federal grant program, and SAMHSA has a number of great grant programs. They've got the block grants, the state opioid response grants, for example. DOJ has grants like the COSEP grants. These are really, really important for local governments to help support their operations. But Jeremy, to your point, they're not sustainable. They are at the mercy every year of the congressional appropriations process, right, which is broken. Right now, we're not even functioning, right?
Right.
But then not only that, the administration, whoever is in the White House, it's that administration that gets to pick the priorities of how those grant money are going to be spent, which changes every year. So that's one of the reasons why we talk a lot about Medicaid supporting these services, because it would provide a more stable source of funding. The other thing about Medicaid is that there are standards of care in Medicaid, which are really important. And so if these carceral settings were to be billing Medicaid for services, they'd have to have a certain standard of health care. And, I don't think it's surprising to folks who are listening. There is a really dramatic differences in the level of quality of care depending on where a person is located, that is dependent upon these budgets. And so having that standard of care across the country, I think, would be really important in improving the overall health of this population.
For those who may not be familiar, why is Medicaid more stable? Why is it less susceptible to political ups and downs?
Medicaid is mandatory funding, so it doesn't depend every year on Congress passing an appropriations bill. So right now, for example, the government, as many of you know, is closed. Because there has not been a funding bill passed for 2026. But Medicaid and Medicare and CHIP are continuing because they're not part of that process. So that does help. The other part is that a lot of these grants, they're competitive. And so, it just depends on, the success of winning these grants is going to depend on how good your grant writer is, right? That doesn't give me a whole lot of confidence, right? But there are also like the big block grant programs, which are great, and they're providing a lot of funding, but they're also done on an algorithm. So as your data changes, so some of these grant programs, for example, are taking into account mortality rates. Well, then for communities who are succeeding in bringing down the mortality rates, what they're doing is obviously working. They then will get hit by lower grants the next year because they're a victim of their own success in some ways. So that's why the grants, it's really important to have these grants and to be creative in how you're braiding together this funding. But Medicaid would allow for a more stable source of that funding.
Another aspect of this, too, I guess there would be a concern that if you open the door 100% to Medicaid funding, and this may have been part of the conversation back in the 60s, if Medicaid, it would be easy to see how there would be significant market pressure to make Medicaid the either the vast majority or even the totality of all healthcare expenditure through a county jail. There would be, so while that would be perhaps great at the local county budget line, that there's administrative burden that probably passes through the state. I mean, TennCare is one of the largest state expenditures we have. Most of the federal funds we get are for TennCare, other than education. And it gets wrapped up in these conversations. These bills wouldn't do that, though, right?
So neither the Reentry Act or the Due Process Continuity of Care Act, neither one of those would expand the Medicaid population at all. This is just for existing beneficiaries. What I think is interesting is, let's go to the Due Process Bill, for example. So it's called the Due Process and Continuity of Care Act. This bill is being championed by Senator Bill Cassidy of Louisiana. And when you hear Senator Cassidy talking about this, he's talking about this in terms of your constitutional rights. So in the United States, as everyone knows, you have the right to due process. You cannot be punished for a crime until you are proven guilty. And the assumption is you are innocent until proven guilty.
Right.
Senator Cassidy, when he's been talking about this in the past, talks about how people are getting arrested and they're having their health care stripped from them, and that you're essentially punishing them before they are being convicted. So it's not just about a fiscal, like who's fiscally going to be responsible for covering these healthcare. There are these basic constitutional issues. There's Eighth Amendment concerns. There's these due process concerns, which also go into this, which, in my opinion, are very compelling as well.
Yeah, it's foundational to our core constitutional philosophy, like you just mentioned. Innocent till proven guilty is the cornerstone of our entire legal system.
Absolutely. And, we really believe that these bills will, in the end, bring down total costs, because the link between substance use and recidivism is so high. So if you can address the substance use, in a setting where we can get treatment in, then you're going to reduce those rates of recidivism. What's really expensive here is not just healthcare, but it's the churn. It's the constant rearresting of people and the burden that has not only on the jails and prisons, but on the legal system. So if we can cut off that circle, that constant cycle and churn, then we will see cost savings. Not only that, it's going to save us money, and it's going to make our communities safer. So if we can get evidence-based treatment that we know that works, we cut off that cycle of recidivism.
We hear from sheriffs and jail administrators all the time that our county jails are becoming the largest mental health facilities in the state. And like you mentioned up top, this is not what they signed up to do. They signed up to lock up bad guys, and they're functionally being charged with being healthcare provisioners.
Another really common sense policy that we really would like to see move forward is it's a bill called the Peer Support Act. And it's tangentially related to this, but if we had what this bill does, and it was introduced in the Senate by Senator Tim Kaine of Virginia, and what it does is it makes it easier for people to become certified as peer recovery specialists. This is a workforce that we have that is so valuable and so underutilized. This is where, if we can get some of these bills passed that make it easier for people to become peer support specialists, to have Medicaid and other resources pay for the services that these folks are providing, that's going to be a game changer. If we can get peers operating in the jails, if we have peers in our emergency settings, these folks are connecting people to treatment, they're connecting people to services, and they are going to be a way that if we can invest in this workforce, we're going to save money in the end.
Yeah, the data definitely shows that. And here in Tennessee, we're seeing that being rolled out in a number of different contexts. There are efforts, the governor's initiative of faith-based and community efforts, they're working to get more peer support in jails directly. We have seen county opioid abatement funded programs that have employed a peer navigator directly in emergency rooms. We covered that at Sumner County, for example. Just having a dedicated person who the individual who's just experienced an overdose or is going through withdrawal or what have you, they're far more likely to listen to this individual than some white coat or a law enforcement officer, or, you know what I mean? It's the impact of the peer-to-peer. It's really there for opening people up to receptiveness to treatment. Long-term outcomes are there. There's also, you mentioned workforce. And while this is certainly, that's an aspect we should consider, is this is a viable employment option for people freshly in recovery, their impact on workforce development in turn has been observed. We have the Caring Workplaces Initiative here in Tennessee that employs certified peer specialists that help not only keep people in recovery, but help them stay on top of workforce development opportunities.
Oh, it's tremendous, the impact that peers are having across the spectrum. I was really fortunate. I got to go on a field trip to Chesterfield County Jail in Chesterfield, Virginia. And I got to go and meet with their sheriff, but then I also got to meet with folks that they have who are incarcerated, and they're going through a peer certification program during incarceration so that when they are released, they can have enough credits to get this certification, before or shortly after their release. And so they have a pathway into the workforce that then is going to pay dividends down the road. I mean, there's all of these examples, and they're just so smart. We have, as I think folks in Tennessee know really acutely, a shortage of mental health professionals, of social workers, clinical social workers, and to have this whole workforce of peer support specialists who can be out there. They're not going to be providing the same services, but they really are critical to connecting people and doing all of that. We need to have all hands on deck, and this is a really important aspect of that.
And speaking of connecting to resources and coming back to our original conversation, thinking of the Reentry Act, the 2-week period after release that we've discussed, that connection with care, we hear so often, even when there are resources, people don't know about them. Peers can help with this, but also the funding really is a critical aspect of this too. In terms of improving connectivity, what do you think should be considered in terms of enhancing communication between different recovery ecosystems? This is a little bit abstract, perhaps. Something that comes to mind is like bundled payments for healthcare, like how we'll take different specialties and wrap it up under one bundled payment. Is there some sort of policy lever to consider to wrap up recovery services somehow, or right now are we just talking about too complicated a landscape?
Well, that's such a critical question, and we saw a lot of investment into recovery under the previous administration. The Biden administration, for example, established at SAMHSA the Office of Recovery, which to me, I'm like, how are we, it was like 2023, 2024, and we didn't have an Office of Recovery, right?
Right.
Who managed this and who, made some investments in recovery. So we need to see that going. We need to see recovery ready workforces. We need to provide resources to industries on how to support people in recovery, because there's a lot of hesitation. One of the biggest champions for a recovery ready workforce was now former Congressman David Trone from Maryland. He owns a large business. He owns a kind of a wine distributor in this region. And he talks about how his best employees were those that he was hiring directly out of incarceration. And he was like, talk about motivated individuals who, want to come to work and go above and beyond. So we've got those folks. We need to amplify those voices. But again, recovery is not going to happen without investment. Recovery is not going to happen unless we are making, real concerted efforts. The other part of it too, which we don't talk about enough, is that everyone's going to find recovery in a different place.
Yeah.
That we do a lot of naloxone distribution. and naloxone. We don't distribute naloxone, but we
We
do a
as a
lot of
country.
naloxone. Yeah, and we talk about how naloxone for so many people is the first step to recovery.
Mm.
That yes, naloxone is harm reduction, right? The point of naloxone is not to get you into treatment. The point of naloxone is to make sure that you don't die. But it's really hard to recover if you're not alive. So, these types of things all kind of build up to this recovery ecosystem. And I like the way that you phrased that, Jeremy, is like it's not just one thing. It is a whole ecosystem of supporting workforces, supporting grants and policies that get you there.
So access to treatment in jails, connection to care upon reentry, peers within the jails and in the communities, in the hospitals to help connect you to the local resources. These are some really critical points of intervention, it sounds like.
Making sure that people don't fall off of Medicaid or their health insurance, right? We do know that when people lose coverage. So there are some estimates. I think it was the Center for American Progress put an estimate out that said 1.6 million Americans who are currently receiving treatment that is funded by Medicaid could lose their health care coverage in the next few years because of the One Big Beautiful Bill. So there's 1.6 million Americans who are in treatment right now are going to be facing a cliff. So we need to be really cognizant of how do we get those folks, make sure that they stay connected.
I'd like to quickly touch on that, actually. There is a lot to the reforms to Medicaid in the OBBBA.
Mm-hmm.
And of course, the most talked about is work requirements.
Yeah.
So Tennessee is not a Medicaid expansion state. So most of the cuts actually don't even apply to our state.
Mm-hmm.
But there are some other aspects of it that do.
Yep.
The work requirements are part of this. However, I do believe there's also an exemption for work requirements for people with substance use disorder.
You're right. So HR 1 does have a work requirement. So I believe it's 80 hours in a month. Folks have to work in order to be eligible for Medicaid coverage. Right now, this is now shifted to the states. Congress has passed the bill, President Trump signed it, and now it's up to the states to implement it. So what you're going to see is 50 different versions of what these work requirements are going to look like. So it's going to be up to each state to come up with those definitions of who qualifies, how that 80 hours is calculated, what systems they're going to use. So like if, they're going to rely on an internet-based system, how complicated is this going to be? What are they going to do for people who don't have access to the internet, et cetera, et cetera. There is, however, written into the law an exemption from work requirements for people with a diagnosed substance use disorder.
Right.
So one of our concerns is that for a person who may be struggling to hold down employment because of a substance use disorder, they don't have insurance. They don't have Medicaid, which would allow them to go to a doctor to get that screening and diagnosis. So it creates this kind of catch-22, right? And so it's going to come down to how are states going to require folks to, how are they going to make them substantiate whether or not they have a substance use disorder? And then also how long that substance use disorder exemption is going to be allowed. So we know that substance use disorder, so if you have a diagnosed substance use disorder, it's a chronic recurring brain disorder. Are states going to say that this exemption lasts for 1 year? Are they going to say that exemption lasts until you're 65? Like it's going to come up to each state to figure out how that works. And so we're all kind of holding our breath to see where states land on that.
I was going to say, yeah, there's going to be a lot of different ways this rolls out, and some states will probably do it faster than others. And I know there are a number of states who already have work requirements in place, Georgia, very famously, and they're nearby us, of course. Mm-hmm. Yeah, this is going to be really interesting to see. All right, well, we'll stay on it. And I guess, lastly, I might ask, other than the policy options we've been discussing today, and I'm very happy that this has been a very policy-heavy episode, are there other strategies we could be considering?
You know, I work for an organization called the Global Health Advocacy Incubator. The idea is that we incubate ideas, right? We incubate public health policies and we work to advocate on their behalf. And really, it's the states that are where all of the good policy ideas the great policies need to bubble up to Washington instead of go pushed down from Washington.
Yeah,
And so
absolutely.
that is going to be really, really important. It's always been critical, especially, in this particular, in substance use issues. It has to come down to the people at the front lines.
Mm.
We have to, the folks here, I work with very well-meaning, incredibly smart people on Capitol Hill, but most of them, if not all of them, have never actually worked on the front lines of this issue. And we need to be hearing more from people on the front lines on what is actually going on. If not, we're going to have a bunch of solutions in search of a problem, right? But then and so, and I say this as someone who spends a lot of time walking the halls of Congress. What we need to be doing is creating that pipeline. We need to be communicating up to the Hill. My team, we need to be learning from the smart things that you guys are doing in the field so that we can replicate those things nationwide. But then also we need to hear the things that aren't working. What are those barriers? There are lots of common sense things that we can be doing here in DC to help folks on the ground. But if we don't know, then we don't know.
Right.
So I would encourage everyone, reach out to your member of Congress, let them know what's going on, let them know what challenges you're facing or what barriers you're facing. And that's the only way we're going to kind of make it through these next couple of years that you're going to be tumultuous in terms of, how these things are being implemented.
All right. Any final thoughts?
I am just constantly in awe of all of the folks that I meet with who, again, are on the ground, boots on the ground, who are doing this day to day. Kudos to everyone out there who are doing the work every day. I feel extremely lucky to be working on an issue that I care so passionately about. And I'm just very inspired by everyone out there who's doing this every day. So, just wanted to express my thanks and gratitude.
The local stakeholders, the local prevention and recovery champions, there's some, kind of like you said, about the most resilient, hardworking, optimistic people you'll ever meet. So, well
Absolutely.
said.
I'll give Jeremy all of my contact information. We want to hear those ideas. We want to hear what's working. We want to hear what's not working. And I will also say one other final thought is that Congress right now and what's going on in Washington, it feels very broken. And it is, right? Bipartisanship is no longer in vogue, right? The infighting is real. However, I still believe that substance use disorder, the opioid crisis, and overdose prevention, these are the last bastion of bipartisan cooperation. I really do think that in many ways they're nonpartisan. The policies might be partisan, but there is tremendous agreement from both Democrats and Republicans that we have to find solutions to this. And so that's why I remain very hopeful that we can move the needle on some of these policies, because unfortunately, the overdose crisis has hit every congressional district. It has hit, a majority of families across the country either have someone in their family who is suffering or know someone closely who is. And so I just wanted to tell folks that, yes, DC seems broken, but and it is, but there are these points of nonpartisan agreement, and this is where we can continue to make progress.
Beautifully put. Loved that. All right. Libby Jones, thank you so much for joining us on the Smart Policy podcast. I really appreciate it.
Thank you for having me.
For more episodes on in-depth discussions on Tennessee policies related to substance use disorder by a range of local experts, please subscribe to us wherever you get podcasts and visit our website at smart.tennessee.edu. I'm Jeremy Corvellis. Thank you for listening, and see you next month.